influences treatment. I think here in Eastbourne it influences what kind of antibiotics you might be prescribing them.
Yeah, exactly. So it's a very good marker. Curve 65 score is a very good marker on telling us whether people are doing badly, and as you suggested, you can then or likely to do badly, whether you can then tailor your antibiotic therapy through that. It's based on mortality outcomes, but it's very, very weak when you use it at the lower end. So if someone's got a curb 0 or curb 1, there's lots of parameters on this that you don't measure, and that specifically relates to youngsters. So if many of you had a pneumonia, you'd probably do very well to get more than 1 or maybe 2, and you could still be very unwell. You could, for example, have fevers of 39 or 40 degrees. You could have a CRP of 400. You could have infiltrates all over your chest X-ray. You may well not get confused. Your urea is still reasonably difficult to push up. To get a respiratory rate of 30 is also quite difficult. And before you get sort of signs of vasodilation and sepsis, and you're not going to get one for the age. So you can quite easily be very ill and the curb score can underplay that. So I think the thing about all these severity scores, the point to make is that it is no substitute for your clinical skills, and as you progress through your careers, you'll pick that up with experience. But they are helpful. But just because someone's got a curb 0 or 1, it doesn't necessarily mean things are that straightforward. It's much better at the higher end, which is what we're looking at here. When you getting scores 3, 4, or 5 as to where they should be treated in intensive care or high dependency units, and these are the mortalities. So you got a curb score of 5, you're tossing a coin really whether you're going to be alive in 30 days. So there are a significant mortality associated with the higher scores, but I would take the lower ends with a pinch of salt. One of the things we can do, and this is by no means try to read this. This is called the Pneumonia Severity Index, and we don't really use that in the UK, and it's traditionally been a bit of a pain in the backside to do because there's 30 odd points or 20 odd points. But I think in the current climate where everyone's got a smartphone, an app, this is all on there, so you just literally tick through these. Have you got liver disease, heart disease, stroke, etc., etc. And this gives you a much better scoring, certainly at the lower severity end of people with discharging and oral antibiotic therapy. So that's our severity scoring, and then we look at what antibiotic therapies we can use, what management we should be giving, and sort of general management as well. I'm not going to go through all the background behind the antibiotics and the mechanisms, etc., etc. You'll be glad to hear. And I'm merely going to go on to talk one slide on what bacteria cause pneumonia, community-acquired pneumonia. They've got some hospital here. We're going to focus on the left-hand column, and by far and away, the huge numbers, the large numbers are strep pneumonia and Haemophilus influenzae. So these are the two we really need to worry about. And if you look actually down here, right at the bottom, none. That's a huge number there. That's almost half. That's just that no organism has been isolated. But when we talk about atypical pathogens, as I'm sure you've heard, talking about some of these organisms, you can see the numbers are, they do occur, but they are small. By far and away, you need to cover these two on your antibiotic therapy. When we come onto hospital-acquired pneumonia, people think, oh, there's still a lot of atypical pathogens. Well, there are, but still, by far and away, the biggest cause is the top one, Streptococcus again. So that's still the most common cause of hospital-acquired pneumonia, but there are some greater causes in some of these more atypical pathogens lower down. But really remembering the top two are the most important one. So investigations we should be doing. So obviously we've spoken about a chest X-ray. Should we be CT scanning people with pneumonia? What does everyone think? Take your silence as unsure. So in straightforward pneumonia, if something's behaving like pneumonia, I would never do a CT scan. If someone has a community-acquired pneumonia treating, it's improving, there's no benefit of doing a CT scan. You should just do a follow-up X-ray in 6 weeks to ensure resolution. If, on the other hand, things aren't behaving in the way you'd hoped, things are getting worse or they're not responding, you can think about things like a CT scan, and we'll talk about that shortly. Obviously, blood tests, your routine things, something like a CRP is a very helpful marker of bacterial infection. And what normally like to see is a CRP halving, roughly, in about 48 hours of antibiotic therapy. If it hasn't dropped significantly like that, you may need to reconsider your antibiotics or your management strategy or diagnosis. And oxygenation obviously is going to be there. What other tests should we be doing in people with pneumonia, which we don't always do?
If they've got a productive cough, would you do like a culture on their sputum?
Excellent. So microbiological tests. So sputum cultures seems to be, people coughing up volumes and volumes of muck, and it's very straightforward to give them a pot, send off microscopy culture and sensitivity. So looking for precisely which bug you've got, which will again guide your antibiotic therapy. Blood cultures, best taken when they're febrile, but we shouldn't forget things like that. And so, yeah, those are really, really important things we should be doing, which are really basic. Urine antigen test, you can do these are pneumococcal and Legionella tests you can do on the urine, so you can send a urine for an antigen test. They're pretty good and helpful. They sometimes take a bit of time to come back, so you're often halfway down the treatment of doing that, but that's definitely something you should be doing. And then we mentioned a bit about atypical pathogens such as Legionnaires, Mycoplasma. And what we would usually do with those is some of the antigen tests. You can do serology, so atypical viral serology on that. But I think this is slightly smaller print, but there are ways you can test for that. And these are the ones you'd often think about in these, as I say, atypicals, if they're not just doing as well as they should, or they have a slightly non-straightforward presentation. Oh, crikey, that is really small. Sorry about that. Anyway, I'll talk you through this. This is the antibiotic therapy we use at East Sussex. So for someone with low severity, and we've already spoken about the pitfalls with using KERB as your score for low severity. So saying KERB 0-1 is basically amoxicillin. If they have an allergy or they're unsuitable, can't take amoxicillin, you can use doxycycline or clarithromycin. But the take home, and as you go up to slightly moderate severity, the take home for all these is that you do need a penicillin-based penicillin-based antibiotic. And we do see a lot of people saying they're allergic to penicillin. And I think really digging out what this allergy is really important. If they've sort of maybe had a bit of nausea once when they had it when they're 20 years old, and that was 10 years back, it's often worth retrying. Obviously, if they have anaphylaxis to it, then do not retry it. But trying to work out what their actual allergy is really important. And more often than not, people can't actually remember. So, but clarithromycin is your alternative, so macrolide there. And these are or doxycycline, the ones we use here. And as you're coming on to the more severe, we use Coamox, which is amoxicillin with clavulanic acid, and clarithromycin. And then you've just got the if you're penicillin sensitive or allergic, what we should be giving. Don't worry too much about that. I think the take home is penicillin is very, very good for a lot of the pneumonias. It covers most of the major two pathogens we spoke about. Resistance can occur, and we can think about different antibiotics for that. So in the severe ones, that's why we often use a double antibiotic. So just to sort of finish off a bit or move on as we're getting through the pneumonia bit, failure to improve. You've got a man there who's in his 50s. You're giving him all the antibiotics. He's got consolidation on his X-ray. Why isn't this man getting better? Any ideas?
Could it be resistant?
So resistance, yeah, definitely. Anything else? I guess one of the other questions I'm asking you, what are the complications of pneumonia? Not everyone comes in, has the antibiotics, goes home, and they never have a problem again in their life.
I'm not sure if this is right, but could the infection have moved on from the lungs?
Yeah, absolutely,
Yes,
definitely. That's definitely right. Yeah, so metastatic infection, or yeah, sepsis and metastatic infection. And I think sometimes, you know, also, what other complications can you get in the lungs themselves? Can you think of any? Well, don't worry, we'll come on to it. But the other thing is also, you know, you sometimes, if someone is elderly, frail, you can give them the antibiotics. There still does need to be a reasonable immune response. So the other things we should also consider is, in our 50-year-old fictional man, have you done an HIV test? Has he got a normal immune system? Is there something else going on? So we'll just talk a bit about that. But before we do, I thought I'd give you a couple of X-rays to wake you up. So what's going on here? Who wants to have a stab at telling us what's going on in this X-ray? All a bit too scared? So what we can see, left hemithorax, pretty reasonable. And the right hemithorax, hope you can appreciate there's generalized soft upper lobe infiltrate here. That's the fissure coming along. We've got air bronchograms running through it. I hope you can see those sort of lines there, the darker lines. Those are air bronchograms. So this is a right upper lobe consolidation. And what's going on here?
Is the left lung quite consolidated?
Yeah, so there's absolutely. So this is sort of we might call it a veil sign, but if that's the right lung, which is normal, you can appreciate here on the left side this is much hazier. So does anyone know why the whole side's a bit hazier? So you can see this in left upper lobe collapse, but this is, yeah, as you say, this is going to be probably due to an infection. So collapsed lobe we can have. Let's see. And what's going on here? This is one of the failure to improve scenarios.
Is it a left lung pleural effusion?
Yeah, exactly. So there's a large effusion here on the left side, and what is associated, you can see there's a bit of maybe mediastinal shift to the right. So all the mediastinum has been pushed over this way. So this is a large effusion. So you can give people antibiotics as much as you want, but their oxygenation is going up because their lungs full of fluid. And so that could be a parapneumonic effusion, which is a recognised, obviously, phenomenon here, or even an empyema. And the only way you're really going to be able to tell is if you pass a needle into that to try and establish what's going on. So a parapneumonic effusion or an empyema are other things. And any ideas on this one? This is a bit trickier. I hope you can all see the abnormality.
Is it an abscess?
Yeah, excellent, well done. Yeah, so this is an abscess. So this is a lung abscess which can develop. And you can see it's just a bit sort of a cavity in the lung, well, not cavity, sorry, it's an abscess in the lung. There's a fluid level there, which gives you the clue as well. So anything horizontal, that's fluid. And there's another one there. So this is just in the upper lobe. It's different patient. So there's a air fluid level there. So these are abscesses. So these can be, again, the sequelae of a pneumonia. It can turn into an abscess if the lung's really stuffed full of infection, really deep-seated infection. It can cause some necrosis, and you can get some death of the lung, and the lung tissue can form into form an abscess essentially. What do you do about that? Well, I think there's lots of different schools of thought, but it's going to be not a straightforward course of antibiotics, whether you need to drain that, whether that needs just a longer course of antibiotics, I think are really a case-to-case discussion. Yeah, these are the kind of things that you can come across. So the other things we didn't really talk about as well is if you're not getting better with a straightforward antibiotic, we spoke about failure of treatment or failure to improve or something else happening, such as a parapneumonic effusion. But if you've actually got the diagnosis incorrect in the first place, so always need to go back and just review that. So, for example, if someone's had a PE with a little infarct after it, it can often give you an infiltrate on the X-ray. And the treatment for that, as you all know, is not straightforward antibiotics or pneumonia management. There'd be other treatments with anticoagulation, etc. Often bronchial carcinoma or cancer can present like this, and they're often you see with failure to improve pneumonia or recurrent pneumonias or recurrent infections. Pulmonary edema can sometimes mimic pneumonia as well. So, you know, sometimes you see, you know, the X-ray I showed you, the first one with the right upper lobe infiltrate, classic pneumonia, very straightforward, but life isn't that straightforward often. So, the two can coexist as well. So other things I put hemorrhage, foreign body and things like this. This is cryptogenic organizing pneumonia. So these are small print things, but, you know, just check how, is there something else going on? Is this pneumonia? Why aren't they getting better? We've already mentioned resistance to the antibiotic or the pathogen. And then I put antibiotic down at the bottom here. This is, you know, also thinking about, has the cannula tissued? Are they not getting their antibiotics? Have they not had 3 doses because no one can cannulate them? Are they vomiting? Is the antibiotic not actually getting into them because every time they take it, they're being sick? Or if it's an outpatient, are they just not finishing off their course because they don't like it and not telling you? So compliance with the antibiotic, bioavailability, and whether we're actually dosing them correctly are all other considerations. And then we mentioned about host defense. We spoke about these complications, which I think we mentioned all of them. So host defense, I'm talking about things like frailty, HIV, immune suppression because they're on chemo. So anything like that, which is going to make you more prone to infection, that it's not going to be as straightforward. And then we've spoken about the complications. An overwhelming infection, I mentioned, just that you've got to have some immune system to fight it if you're just a bit frail and old, and you can't always. You don't always survive pneumonia. And I think that is pretty much all I was going to say on pneumonia. We've got a bit to do on ILD afterwards. So are there any questions about that side of things at the moment? Or about pneumonia, anything at all really related to that? Shout them out. Yeah. Okay, so if we go straight on, but as I say, as you go through, just shout out or call out throughout. That my setup, I can't actually see if you've got your hands up, so just sort of speak because we'll ignore you otherwise.
Can I ask a question about community acquired and hospital? So is the only classification of them that it's in hospital or it's not, or is it more severe?
So the classification really is community is obviously someone from their own home. They call it is hospital acquired on the sort of guidelines in the books, but really we should be calling it healthcare acquired. So people from nursing homes, residential homes, these sorts of environments, as well as people who've been in hospital previously, are more at risk of slightly, as you mentioned, those atypical pathogens on the list. So you just need to think a bit harder about what we're doing. So here we go. Now, so you're looking at things like mycoplasma. It has a tenfold more common in that group than the community group. Well, when was the last time they're in a hospital had this kind of exposure? It's difficult, but I'd normally say if someone's represented with a pneumonia of 10 days to a couple of weeks of being in hospital, that probably would prompt you to consider covering for hospital-acquired pneumonia. So that would be not just straightforward penicillin. You'd have penicillin and a macrolide cover, so penicillin and clarithromycin. As I say, the trust policies on those specific ones will change, and they change in the same trust with time, but it's just recognizing that that is a separate entity. Also, someone representing with pneumonia from a nursing home, you should probably consider that as a care home acquired or healthcare acquired pneumonia potentially. Does that answer your question?
Yes, thanks.
No problems. And the other thing we didn't also speak about was things like aspiration pneumonia as well. So people can obviously, it's a strange one, but you know, if someone sort of aspirates a cup of tea and it goes straight down into their lungs, or part of it does, you get it. It's called an aspiration pneumonia, but the reality is you probably get a pneumonitis to begin with. Something like a cup of tea is very sterile. It's pretty much boiled water. So it's more of a chemical pneumonitis you get, and then you get a bacterial overplay on top of that. So so that's something else that we should also just sort of touch on, I suppose. Anything else to do pneumonia, or we can just crack on with some of the interstitial lung disease? Okay, so I'll go through this reasonably swiftly. There's quite a few slides here. We're not going to go through all of them. And this is really just to give you a bit of an insight into what interstitial lung disease is, what we shouldn't be doing, what we should do, and some of the slides we're going to just flash by because I don't think they're going to be that relevant to us today. So again, the first question for all of you is, we see this, we write it in the notes, we copy it from Clarking's, we read it on letters, but what is interstitial lung disease? And I think that's quite a difficult thing to answer, so I'll answer it for you. And we do know we don't have a specific two-liner for this as an answer, but there've been lots of different descriptions over time. These top two are really relatively historical, but you've probably heard about things like cryptogenic fibrosing alveolitis, which is a reasonable term because some of these things are cryptogenic, so we don't know what it is. Fibrosis can be part of it, but they're not really an alveolitis, or not all of them are. Things like pulmonary fibrosis, so fibrosis, as we mentioned, can be part of the process, but isn't the whole entity of a lot of these interstitial lung disease. And then we've got ATS is the American Thoracic Society, ERS is the European Respiratory Society. So these are just terms that have been coined by them. And we need to classify them because it is quite a wide spectrum of disease. Some are treatable and some aren't really. And it also gives us prognostic benefit. So you've probably seen some of these in the past. The main ones we're going to talk about are, so we know drugs that can cause it, connective tissue, and these are the ones we're going to focus on a bit now. So IPF is idiopathic pulmonary fibrosis. Now these are the, as the name suggests, the idiopathic types, and there's only really two you need to concentrate on, these two here. Don't worry about any of this stuff. UIP is the radiological pattern, which we'll talk about for IPF. NSIP is non-specific interstitial pneumonia, and that's the two ends of, well, not ends of the spectrum, but they're the majority that make up interstitial lung disease that you'll see. As I say, all these do exist, but much smaller print. And so I'm going to give you a couple of cases. I thought that would probably be the easiest way to go through this, and then we can untangle things. So this is a 70-year-old man who's a previous smoker, and he's been getting more and more breathless. So he has shortness of breath on exertion, which has now progressed to shortness of breath at rest. And he has got no non-productive cough. This was his X-ray. What does everyone think about that, or anyone think about that? Given the title, you can probably say he's got interstitial lung disease, but that's cheating. Any comments?
There's it looks like there's a pacification all over the lung. To be honest, it looks.
Yeah. Yeah, absolutely. So as you said, this bilateral infiltrates, and yeah, this sort of haziness or a pacification, but bilateral infiltrates throughout both hemithoraces. Yeah, this maybe looks a bit more normal up here, but the rest of it looks a bit grey and mucky. So he went on to have, what other things we did for him? He went on to have a CT scan. Not sure how many CTs you guys have all looked at, but just to sort of orientate you again, these are the axial images. So he's lying flat on his back, spine at the back here, scapula there and there. Head is somewhere into the screen, his feet are somewhere pointing at us. So we're looking up at him. This is the left lung, right lung, and this is obviously level of the carina. You can see how grey these lungs look. And if you're not sure whether the lungs look grey or not, and what's grey and what's black, black is air. So look in the trachea and the main bronchi. So that's black. So this is clearly quite grey. It's sometimes difficult to appreciate that when everything's grey. This is just a slightly higher up. You can see this black stuff here is normal lung, but he's got patchy grey stuff. And how would you describe that? Anyways, you describe that other than patchy grey stuff? So this is ground glass opacification. Okay, so they say it's as if you're looking through ground glass, and everyone goes, well, I've never looked through ground glass, or through a veil kind of thing. But so it's this greyish ground glass opacification. And these are non-specific. You see ground glass in, if you scan someone with pulmonary edema, you'd see that. You'd see it in a variety of things. But what we do know, if this is fluid, if he's lying on his back, it should be dependent and he should have some effusion. So there's other markers of fluid there. Right, and this is the one everyone hates. I hope that projects okay. Who wants to have a hazard at talking us through this or saying what they see? So I'll talk you through the figures because they're probably different to what you're used to seeing. So this is VC max. FVC is your forced vital capacity and your FEV1. So let's just concentrate, and this is your FEV1 to FVC ratio. So let's just concentrate on these three lines here. So his predicted is 1.89. Sorry, his predicted is 3.09 and he got 1.89. So he got 61% of predicted on his FVC and 65% of predicted on his FEV1. And his ratio was predicted 74, he got 73. So his ratio is normal. Well, what does that mean to anyone? And this is his graph here, his flow volume loop.
Does that mean it's restrictive?
Good, yeah. So he's got lower dynamic volumes, and you can see on his loop that it's definitely doesn't go all the way out, so it is reduced, and his ratio is preserved. So he's got a restrictive spirometry, and this is the gas transfer. So this is your total lung transfer coefficient, 21%, and when it corrects for the volume, it's 41%. So we know his lungs are a bit smaller, or we don't definitely know that, but we think he's got a restrictive defect. So he corrects to 41%. So very low gas transfer. So without knowing too much about this chap or too much about interstitial lung disease, what do you want to do for this guy? Just tuck him up in bed and say, there, that's your hand. Anything anyone wants to do? So I'll tell you what we did. Oxygen, good. Yeah, okay. So basic measures, yeah. How are you going to treat that ground glass changes? What do you think it could be due to? So let me tell you what. Oh, there we go. What's our plan? So oxygen, good. What other things should we be considering? So he's got a basically an inflammatory process on his lungs. That was very inflammatory there. Steroids is, yeah, good option. And what do you want to know about before we give him steroids? What does steroids do to your immune system?
Suppress it.
It can suppress it, yeah. So we do know that I think steroids is not an unreasonable thing to say, but what we often do in these patients would just make sure they haven't got infection in their lungs. So we'll do certainly, something like COVID could give you a reasonable picture like this, but you can get a reaction to it. So we actually did a bronchoscopy, I think, on him. Yeah. So so we did a bronchoscopy to rule out any infective process. And then we treated them high dose oral steroids as you suggested. So that's something that has significant ground glass, and that will be something that's most likely to be steroid responsive, having just excluded the fact that he had any infection in his bronchoscopy. So washed out the lungs, no infection, gave him some steroids. And this was his scan afterwards. And you could see that's much better, much less grey, much more like the airways blackness here. And then this is his lung function afterwards. So you can see his flow volume loop has come right up to normal. All his numbers are 100% or better on all the on the spirometry. And his gas transfer, it was, I think, 20%. It's now 65. So not totally normal. And the corrected transfer factor was 80%. So significant improvement. And this guy did dramatically well, got dramatically better. The thing we don't really know with him is still what's driving it. So the question for a longer term is whether you can stop the steroids or need to continue it. And I think that's the difficult one to answer. So that's the first case. I was just going to quickly show you. And then this is kind of a second case to try and show you a very different presentation of something. So this is a 75-year-old man who's had a gradual onset of breathless over several months. So very different from the last guy we saw, which was very acute or subacute. He's had a dry cough, and the classic sort of scenario in these patients is that they're steadily getting more breathless over 18 months or something, and they'll tell you, well, you know, I could always walk the 9th hole, which is slightly uphill, but now I'm breathless and have to stop twice before I get to the green or something. So it's a very insidious process that they have. And this guy, we went on to have a CT scan. And just to sort of talk you through this is, I hope you can appreciate, this is very, very different from the last chap's CT. And what's all this down here? Does anyone know what we term this stuff down at the bottom? Here and here. So that's honeycombing. I don't know if you've heard that term, but that's honeycombing. And that's a hallmark of fibrosis. And the pattern is very specific in this case as well. And he's also got very subtle changes around here as well. Okay. So, oops. And this was his lung function at that time. And once again, I'll just talk through this because we need to sort of finish up in the next 5 minutes or so. He's got the flow volume loop is there. That one is his predicted. So it's inside his predicted. And he's got reduced numbers as a relatively preserved ratio. And once again, his TLCO was down in his boots. It was 14. And his gas, so this is gas transfer, significantly reduced with a restrictive defect. We won't worry about the lung volumes at the moment. So the two cases just give you a comparison and shows you the two ends of the spectrum, where you have one which is a very acute or subacute process and one which is a very chronic process. And the more chronic one is classically what we see in this idiopathic pulmonary fibrosis, which is a very slow fibrotic disease which progresses over time. And this is essentially a bit more about the IPF, the idiopathic pulmonary fibrosis. It's a very specific form of interstitial lung disease. And it can be, we see this often find incidentally, someone has a scan for some other reason. And because we know that the diagnosis is, it can be delayed, people often try a few inhalers, have a few courses of antibiotics from their GP, still not getting better. So you can often be well into your symptoms before it's diagnosed. So we'll just crack through that. The other thing we also know is that it's really easy, or if you're not thorough, to miss another cause for pulmonary fibrosis or interstitial lung disease. And the things that we should really be looking at on all the history and examination are there. So we would do on the diagnosis, the CT is the most important thing, and the pulmonary function test, as we mentioned. And also we would do a full autoimmune screen on these patients to make sure it's not a connective tissue disease related ILD. And these are the things that I'll just go straight into the pictures for you. So this is honeycombing. These are the things that you'll see in IPF. You get this peripheral change. So the bit in the middle of the lung is reasonably preserved, but we do get the first changes around the edge, so around the pleura, and that's called subpleural, so just under the pleura. That's where you get the fibrosis to begin with. You then get it at the bases predominantly, and this is classic honeycombing at the bases. And that's the way in which you make the diagnosis more and more is with CT scanning. Biopsies, a bronchoscopy and things like that are not particularly helpful. They can be helpful, but are not used that regularly. And CT scanning is getting so important in diagnosing these things now. I'm not going to bore you with this. And I think we are coming to the end. The one thing I did want to mention is about treatment of this. So when you see these two specific entities on take or on your wards or as you're moving around, one of the things to bear in mind is that that second type we spoke about, the IPF, is not steroid responsive. There have been lots of treatments and trials that have been tried for that, and steroids, these patients don't do better. They just put on weight, develop diabetes and have GI bleeds. So a lot of the trials with that previously were stopped early because it was unethical to continue them. Compared to the first case where they have that very short history, lots of ground glass and inflammatory, that is where you can consider treating that urgently. There are other medications, pirfenidone and nintedanib, which are anti-fibrotic treatments for the IPF. Lung transplantation is great if you can get it, but organ donors are the problem. So I was going to literally just stop there and just leave it if you had any questions for me. I know we've sort of been going for a bit. I apologise for the sort of glitch at the beginning. Any questions about anything we've discussed with the interstitial lung disease or the pneumonia for that matter there? I know there's quite a lot of stuff we've just sort of thrown at you. Anything you wanted to ask or anything that was unclear? No? Okay. So when you're going back to your wards and various places, I think those are the things that we should be looking at. So the pneumonia, thinking a bit about what we're doing, what antibiotics should be starting on, looking at the trust policies. Things we didn't really focus on around there was the basic care as well, with the smoking cessation, the thromboprophylaxis, hydration, and sort of more holistic care of the patient. And the same would be applied to the interstitial lung disease, but trying to differentiate between the sort of chronicity and the acute ones will be one of the most helpful bits. Okay, well, I think if everyone's happy, and if there's anything related to what we spoke about or anything otherwise respiratory, feel free to ask now if there's anything you wanted to run through. Otherwise, we'll terminate it there.